Morning everyone, welcome to the Institute for Work and Health's speaker series presentation for the 19th of October 2021. My name is Peter Smith. I'm a member of the scientific staff here at the Institute, and I'll be introducing myself today to tell you a little bit about some of the things we've learned about COVID-19 protections, some findings from some population level data in Canada. Just a reminder for those of you who'd like to ask questions, if you want to type your questions into the chat box throughout the presentation, we'll answer them at the end. So my colleague Sarah McDonald will come on at the end of the presentation and she will answer, or she will ask me any of the questions that you've put in the chat box and we'll answer them. For those of you who are joining us for the first time, if you wanted to hear more about some of the news and events from the Institute for Work and Health, you can subscribe at iwh.on.ca/subscribe. So let's hop into today's presentation. So I'm going to start with the take-home messages for today. So the three take-home messages are that in a large sample of Canadian employees who are working outside of the home in the period of July to September 2020, we found generally high levels of self-reported infection control practices to reduce the spread of COVID-19. Over the period of April 1st, 2020 to March 31st, 2021, workplace outbreaks in Ontario accounted for 12% of all COVID-19 cases and about 7% of all hospitalizations among working age Ontarians. And then the third take-home message, which we'll sort of cover as we get through each of the different data sources and the findings, is that despite the workplace being identified as an important site for COVID-19 transmission from pretty early in the pandemic, we actually haven't had a lot of consistent data collection to understand the relative contribution of workplace transmission compared to transmission from other locations. And there's some of the challenges that I'll be walking through today as I present the two studies that we have. So in terms of the background, the workplace has been identified as a potential location for increased transmission. And as I said, that was relatively early in the pandemic. You just have to think back to the prescriptions about people working from home if they could work from home. And so the workplace was recognized as an important site, potential site of COVID-19 transmission. And it makes sense because workplaces are settings where people from different communities come together. So you've got a variety of different communities coming together in the one location, working in close proximity of each other. The workplace is also important because the levers you could use to prevent COVID transmission are potentially easier to implement in a workplace setting than in a non-workplace setting. You think about infection control procedures such as people wearing masks, you can probably implement and enforce those easier in a workplace setting than you can in a non-workplace setting. And some of the previous work which we've done with the occupational health clinics for Ontario workers has shown that lack of PPE and other infection control procedures not only increase the risk of COVID transmission, but are also associated with higher levels of anxiety. And we've found this both among healthcare workers and also among non-healthcare workers. So there are two questions that I'll be answering today with two different studies, which we've done in conjunction with colleagues at Public Health Ontario. The first one is, what were the levels of workplace infection control practices among workers who were working outside of the home, so continuing either to go to the workplace or working outside of the home in multiple locations in the period of July to September 2020. And the second question is, what were the rates of cases of COVID-19 due to workplace outbreaks between April 2020 and March 2021? And how do these compare to rates of non-workplace outbreak cases? So we did hear from various people within public health that workplaces were driving case counts in Ontario. But when we look at the data, how accurate was that assessment? So this is the period of time that we'll be looking at today, going from April 1 to the end of March 2021. The blue line on this graph is all cases of COVID-19 among the working aged population. So these are people from the age of 15 to 69 years of age. And then that's all cases, sorry, is in the blue, that's everyone. The working age population is in the gold, which is people 15 to 69 years of age. And you can see they sort of track along fairly equally with each other over this period of time, covering the first wave of COVID in sort of April, May 2020, and the second wave and into the start of the third wave at the end of March. So for the first study, we're going to focus on this blue shaded area, which is this period from July to September, where we actually had relatively low case counts in Ontario. They were increasing towards the end of September. So the data source for the first study is Statistics Canada's Labour Force Survey. And this is important. A lot of the work that's been done to understand what's happened in the workplace around COVID has had to use convenience-based samples. And this was important because we needed information to be collected relatively quickly and to be able to assess things as they were occurring. But it does, whenever you sort of recruit a convenience-based sample, there are issues around selection that might influence your results. Statistics Canada's Labour Force Survey is not a convenience-based sample, it's a probability sample. So that's why it's a great source of information to use for this particular study. So starting in April 2020, in the Labour Force Survey, they included a supplement which asked COVID-related content, and they asked that to a proportion of people who are completing the Labour Force Survey each month. In July, August, and September, they included questions on workplace protections, but only in those 3 months. So in the sample in July, there was just over 63,000 people interviewed for the Labour Force Survey. In August, just over 67,000 people, and in September, just over 70,000 people. Questions on work arrangements were only asked of people who are aged 15 to 69 years of age and who were not members of the Canadian Armed Forces. So this reduced the sample over the 3 time windows to just under 78,000 people. Of this sample, just over 50,000 were working in a fixed location outside of their home, and just over 10,000 working outside of their home but in no fixed location, so they were moving around. And these were the people who wanted to ask the questions about workplace protections because they were working outside of the home. If that proportion seems large to you, it also seemed large to us that we had over 70% of people working outside of their home in this period of time. We did have just over 53,000 responses from paid employees, and they're our analytical samples. So questions for self-employed workers were more challenging because a lot of them were about what the workplace was doing, and as well, information on occupation isn't collected among self-employed workers, and they were important covariates that we wanted to include in our analysis. So the infection control practices, there were 4 ones which were specifically assessed. One was around workplace or work practices being reorganised to allow for physical distancing. The second was around access to personal protective equipment. The third was around increased access to hand sanitizer or hand washing facilities. And the fourth was around enhanced cleaning practices. There was a 5th question which was around other protections that are in place, and respondents could also indicate that no measures were in place in their workplace. So it's important to recognise that there are potentially important infection control practices such as ventilation, which were not asked in the survey. It's given when the survey was conducted around July, August, September of last year. Certainly, I would hope that if a survey was conducted now, that there'd be more attention paid to airflow and ventilation, as there is a better recognition that surface transmission is a relatively small proportion of transmission of COVID-19, and most of the transmission occurs either through droplets or through airborne routes. Other measures that we included where we looked at how these measures were related to the prevalence of different infection control practices. We had a lot of information on demographic characteristics. So we had people's age, sex, immigration status, race, marital status, if they had dependent children, levels of education, their province of residence, and where they lived, in an urban or a rural population. In terms of the occupation that people were in and their employer, we knew if they were working for a public or a private employer, they were members of a union or a collective bargaining agreement, their hours of work, if their work was permanent or non-permanent, if their work hours varied, their job tenure, so how long have they been working at their employer, their hourly earnings, if they worked indoors in an environmentally controlled environment. We did that, we assessed that using the ONET classification system based on their occupational classification. We also knew their industry of employment, the size of their workplace, if their employer had multiple locations, and if the workplace allowed for employees to work from home, either partially or fully. So a lot of different information in the labour force survey that we could use to understand what factors were associated with higher or lower rates of infection control procedures. This just shows you the distribution of infection control practices as assessed in the labour force survey among employed labour force participants working outside of the home. You can see that in general, rates of infection control practices were fairly high. The lowest here being physical distancing procedures, where 84% of workers said they were in place. The highest being hand washing, increased access to hand washing and sanitising facilities, where more than 90% of workers said that those practices were in place. 88% for PPE and 86% for cleaning, with 4% indicating some other type of practice. In terms of the number of infection controls, a very small proportion, 2% of the sample, had no infection controls in place, although 2% of approximately 11 million people is still quite a lot of people. But the positive news was 72% of our sample had 4 or more of these practices in place in their workplace. In the interest of time, because I do have a second study, I'm only going to focus on physical distancing and PPE practices, and I'm only going to talk to you about industry. I will summarise the other results, and I'll give a link at the end of the presentation to the paper, which will be out in a couple of weeks in Health Reports, where all the other information is involved. And I'm certainly happy to take questions about other information at the end of the presentation. So this graph here looks at the adjusted prevalence of physical distancing by industry groups. So the reference here is healthcare and social assistance, where 83.3% of the sample said that they had some type of physical distancing workplace practice that had been put in place in their workplace. The red bars indicate where the prevalence of physical distancing is lower than it is in healthcare. The blue bars indicate where it is higher than in healthcare, with the asterisks against the left-hand side axis indicating where there's a statistical significant difference in terms of the prevalence of physical distancing practices. As I said, these are adjusted prevalences rates, so these have been adjusted for all the other measures that I previously described in that previous slide, both from demographic characteristics, occupational characteristics, and other workplace characteristics. So you can see in this graph that the physical distancing practices were lowest in construction, which was different from healthcare, highest among retail trade, and in accommodation and food services, which were both statistically different from healthcare, but a lot of variation across industry groups. This is the presence of PPE by industry group, and again, the reference is healthcare and social assistance, where we would expect the presence of PPE to be highest. Certainly at this point, we know it's been well documented that at the start of the pandemic, the presence of PPE or access to PPE was not optimal among healthcare workers, but now we've moved forward to July, August, and September. Again, interesting to note, accommodation and food services rates of PPE were as high in that industry as they were among healthcare and social assistance workers. Low rates in agriculture and primary industries, low rates in construction, and also low rates in education, as well as manufacturing and wholesale trade. Other groups where we found lower levels of protections, so men compared to women had lower levels of all infection control practices. Workers with lower levels of education had lower levels of physical distancing and less access to enhanced cleaning in their workplaces. Workers who had shorter job tenure, so less than 6 months, were lower on all infection control practices compared to workers who had been with their employer for 5 or more years. Non-permanent workers had less access to PPE and less access to enhanced cleaning practices. People in smaller workplaces, so fewer than 20 employees, had less access to PPE. And workers who had no option to work from home, so as employers required all workers to be at the worksite, had less physical distancing and less enhanced cleaning practices. All these differences were in the range of about 2% to 6%. So again, fairly small differences across the groups. Interestingly, no differences across unionisation or collective bargaining agreements, and no differences across either racial, immigrant groups or across hourly wages. So to summarise this first study before I move on to the second one, rates of infection control practices are generally high among Canadian workers. It's an open question as to how high is enough. As I said, we found here at least 85% of workers had access to different infection control practices in their workplace, sometimes been over 90%. Ideally, obviously, we'd like to see that around 100%, but still quite high in this sample of workers. We did observe a lower prevalence of infection control practices in some industry groups, in particular construction, agriculture, transport and warehousing, and non-food manufacturing, and also among employers who didn't provide an option for people to work from home. We also observed a lower prevalence of infection control practices among workers at the start of their employment, workers in non-permanent relationships, and those at lower levels of education. It's important to note that these are groups that we generally observe weaker safety practices among. So these are groups where we've traditionally observed higher rates of work injury through to less access or increased exposure to hazards and less access to protections in place in the workplace. And this continued to be the case for these groups in the context of COVID-19, although as I indicated before, the groups were fairly small, between 2 and 5%. So I'd now like to move on to the second part of the presentation today, which is talking about assessing COVID transmission at work. And this has been certainly an interest of ours at the Institute for Work and Health, but it's been a very challenging area to get into to try and understand how much of COVID-19 transmission has occurred in the workplace compared to non-workplace settings. And some of the challenges involved in doing that is the risk of transmission of COVID is continuous across all settings. There's very few settings where someone's at no risk of being infected with COVID-19 because it is person-to-person transmission. So, you know, when you're going to work, when you're at home, when you're outside of work in a non-work setting, there is still a risk of COVID transmission. Admittedly, the risk does change across settings, but there is very few settings, unless you're by yourself and no one else has been in that environment, where there is zero risk of COVID transmission. Some people have tried to estimate or try to understand risk of COVID transmission among workers using very historical estimates of labour force participation, such as the 2016 census. But these don't really tell us who's still working. We did see very large reductions in employment at the start of the pandemic. We don't know who was continuing to still go to the workplace and who was working from home. And so the historical estimates from 5 years ago don't really give us a good snapshot of who is currently going to the workplace during the COVID pandemic. Population level data of work-related information among positive COVID cases was restricted to whether someone was a healthcare worker or not. And a lot of that was driven by worrying about if healthcare workers would infect patients, not really worried about healthcare workers infecting other healthcare workers at the start of the pandemic. Public health units do collect information on workplace outbreaks, and I'll talk about that on the next slide. However, outbreaks in education, in healthcare and in congregate living settings didn't distinguish between outbreak cases among workers compared to outbreak cases among non-workers. So together, these challenges have really limited our understanding of what is the role of the workplace in terms of COVID transmission. So what are workplace outbreaks? So we're going to be using workplace outbreaks. I'll be presenting findings based on workplace outbreaks. So different public health units are responsible for declaring outbreaks within their geographical area. Usually, in most industries, this is when 2 cases occur in a 14-day period, and these 2 cases can be linked. So there's no chance that the 2 cases are linked through activities outside of the workplace. So it's a relatively restrictive definition. I've got an asterisk here because it does vary by industry throughout the pandemic. So at the start of the pandemic, in certain industry groups such as healthcare, 1 case was enough to consider that a workplace outbreak. And one of the challenges around workplace outbreaks is different things happen. So sometimes when there's an outbreak, there's an increased amount of testing. And so you can pick up more cases in an outbreak than you would pick up in a community setting. And of course, we don't know the extent to which there's consistency across public health units in terms of how they have declared outbreaks and how they've identified those outbreaks that have occurred. In terms of rates of workplace outbreaks, so this is the numerator we're going to use in this particular study. Public Health Ontario retrospectively assigned all outbreak cases that they'd received into one of 13 different industry groups. And they also disaggregated the worker cases from non-worker cases in education, in congregate living and in healthcare settings. So we're able to tease apart those which you weren't able to do in the publicly available data. The Institute for Work and Health, we provided the hours spent at the workplace across these same 13 industry groups using the supplementary questionnaire from the labour force survey that I mentioned in the previous study. The analyses we conducted were across 3 different time periods. So April 1 to August 31st, 2020, September 1 to December 31st, 2020, and January 1st to March 31st, 2021. What we did is we calculated a standardized incident ratio for each industry group by time period. So what we did is we calculated the rate of COVID transmission per 200,000 hours worked, and we compared that to the overall rate of COVID-19 among Ontarians aged 15 to 69 years of age per 200,000 hours awake. So we assumed that in the 16 hours that someone was awake, they were at some risk of contracting COVID. And then we assumed that when people were at the workplace, they were at risk of contracting COVID through a workplace outbreak. So a standardized incident ratio greater than 1 indicates that the rate of workers per hour worked in that industry was higher than the overall rate of COVID transmission in the working age population. And vice versa, for when the standard incident ratio is less than 1, that indicates that the rate per hour of being exposed is lower in that industry setting than it was in general at the population level in general per hour of being awake. So this describes the 3 time periods. The blue shading on the left describes the first time period we'll be looking at. The white in the middle describes the second time period we'll be looking at, and the blue on the right-hand side of this describes the last time period we'll be looking at. You can see over these time periods, the number of COVID cases among the working age population increased. So it increased between the first and the second time period, and then it increased again in the third time period. I'm presenting a standardized incident rate. So you need to understand that the reference group, which is the general rate among the working age population of all cases, is increasing over time period. So while you might see the standardized incident rate fall, it doesn't mean the overall rate of COVID transmission has fallen. In fact, across all industry groups, we see increases in rates of workplace outbreak over time. So this graph describes the proportion of all cases and all hospitalizations due to workplace outbreaks among people aged 15 to 69 years between April 1, 2020 and March 31st, 2021. Over the whole time period, 12% of all cases among the working age population could be attributed to workplace outbreaks, and 7% of hospitalizations. You can see that the proportion of cases was highest in this first time period between April 1 and August 31st, primarily driven by the large outbreaks that occurred in agricultural settings, reducing to 11% of all cases attributed to workplace outbreaks in the second and third time windows, and 6% of hospitalizations and 7% of hospitalizations. The hospitalization rate is interesting. This could be a healthy worker effect. So people who are able to go to work who are 15 to 69 years who are working are generally healthier than people who don't go to work. Again, it also could be indicative of the increased testing that occurs in response to a workplace outbreak being declared within a workplace. So you can pick up these symptomatic cases that occur after the outbreak has been declared. This presents a standardized COVID incident rate by industry among this first time period. And again, you can see in that second dot point for agriculture, the standardized incident ratio there is almost 25, so 25 times the risk per hour worked in an agricultural setting compared to the general risk per hour being awake. Also increased risks observed in healthcare and social assistance and in food manufacturing. But generally lower rates observed across most of the industry groups in this first time period. In the second time period, you can see the standardized incident ratios drop. Again, this doesn't mean that the overall rates have dropped. They've actually increased in this time period, but the reference rate among the working age population has also increased by a greater amount in this time period. Again, you can see agriculture, healthcare and social assistance and food manufacturing have elevated rates, but now approximately around 2.5 times the rate in the general working age population, with rates in most industry groups again being lower than they were in the general population. And in the final time period, you can again see the same industry groups, agriculture, healthcare and social assistance and food manufacturing having elevated rates. On the right-hand side of the graph, you can see that transport and warehousing also have elevated rates, about 1.5, with slightly elevated rates or very similar rates among education, and among other types of manufacturing compared to the general population. So just to summarise these findings, so in the period April 1, 2020 to March 31st, 2021, workplace outbreaks accounted for about 12% of all COVID cases among the working age population and 7% of all hospitalisations among the working age population in Ontario. Rates of COVID-19 per hour work were consistently higher than the general transmission rate in the industries of agriculture, healthcare and food manufacturing. And the majority of industry groups had rates of COVID transmission due to workplace outbreaks that were lower than the general transmission rate. And this is about 75% to 80% of the labour force who were going to the workplace were in industries where the rate of transmission was lower than the general transmission rate when we use workplace outbreaks as our numerator. Bringing the two studies together, we can plot here on the y-axis here, the vertical axis are the rates of COVID-19 per 1 million hours worked, and on the horizontal axis, the x-axis is the levels of PPE across different industry groups. So you can see here there are some outliers that occur. So although healthcare and social assistance and food manufacturing have relatively high rates of PPE, access to PPE per million hours worked in the period of July through to September, we found that they also had very high rates of COVID-19 per hour worked in the period of September to December 2020. Although you can see for other industry groups, for construction, which had one of the lowest rates of access to PPE, it also has fairly low rates of COVID-19 per million hours worked, while agriculture and primary industry, which also has a low rate, had a higher rate of COVID-19 per 1 million hours worked. Looking at physical distancing, levels of physical distancing and rates of COVID-19, again, you can see that food manufacturing sticks out here. If you compared food manufacturing at the top here compared to other types of manufacturing, similar levels of physical distancing procedure for quite different levels of COVID transmission. And this points to some of the opportunities for learning when it comes to workplace outbreaks that we haven't done enough in collaboration with public health to really understand why is it that COVID seems to spread in some workplace settings much more than others. It's not just about, I guess, access to infection control procedures, but there must be other characteristics of the environment that are important. And just to drive home that point, this sort of gives you a snapshot of the distribution of workplace outbreaks across each month in Ontario. And what I want you to take from this slide is that, one, that the distribution's got a very big right skew, where there's a small number of workplace outbreaks that occur with a large number of cases. So most workplace outbreaks that have occurred in Ontario are sort of in the level of less than 10 people contracting COVID through those outbreaks. But we have a small number of workplaces where the outbreak has really spread quite large. And this is a consistent finding throughout each of the different months. You can see that there are these dots at the end which show that the distribution of outbreaks, we have a small number which occur where we've got more than 100 workers being infected in these outbreaks. And this provides, I think, an important opportunity for learning about what is it about these environments which have allowed COVID to spread. We know from non-workplace outbreak settings that there's a number of different factors that come into play, things around viral load, asymptomatic transmission, ability to transmit COVID. And it does seem that this is replicated in a workplace setting, but we can explore other factors among these settings that might also lead us to better understand what is it that enables COVID to transmit, and what are the things that we should be measuring for the next pandemic that we didn't measure in the current one, didn't measure quick enough anyway. So again, to come back to these three take-home messages before we get into questions. So in this large sample of Canadian employees who worked outside of the home between July and September, we did observe generally high proportions of self-reported infection control practices to reduce the spread of COVID-19. And this is important given this sample is one of the few representative samples of workers in Canada that we've been able to collect with relevant work information during the pandemic. Over the period of April 1, 2020 to March 31st, 2021, workplace outbreaks accounted for 12% of all cases and 7% of all hospitalisations among working age Ontarians. And as I sort of said at the start, and I hope you've picked up that, each of these data sources and each of these studies have some limitations, and I'm sure that we might have some questions about that, and we can answer those in the discussion. And so we really do need to reflect on, despite the workplace being identified as an important site for COVID-19 transmission early in the pandemic, we haven't had consistent data collection to understand the relative contribution of workplace transmission compared to transmission from other locations. And we really do need to focus on addressing this. We need to understand the importance of work as a determinant of health in terms of public health, and do a better job at collecting relevant occupational work information in a lot of our health databases so that we're ready for the next pandemic when it does occur. Some acknowledgements before I wrap up. Just to acknowledge the work of Public Health in Ontario, in particular Sarah Buchan and Brendan Smith, who led the workplace outbreaks findings that I presented today. Other research team members, which were involved in the 2 studies I presented today, a variety of people from Public Health Ontario, as well as Cam Mustard and Faraz Shahidi at the Institute for Work and Health. Also thanks to the excellent staff at Statistics Canada's research data centres for their assistance in accessing the labour force survey for our research and also vetting the output for our project. For more information, as I said, the prevalence and correlates of workplace infection control practices will be published next month in health reports. That publication should be available in a couple of weeks. And the Public Health Ontario article led by Sarah Buchan is under revise and resubmit at the moment, and we hope that that article will be published in peer review towards the end of this year. There is a preprint which is available at the link which is published there in the presentation. And just to note that these slides will be available within a couple of weeks for those who are interested. So with that, I will end, and I'm willing to take questions. I'll put up my email for people who might have questions that they want to ask outside of the session that we have today. Also, if people want more information about the speaker series or the Institute, there are links available there on the slide. So Sarah, I would welcome you joining me so that I can take any questions.
Well, first, thank you very much, Peter, for presenting those 2 studies. I think you've already answered a lot of questions about COVID-19 transmission and infection control practices, but there are many more. So the first one to start with is about PPE. How was that defined in the survey? Respirators, shields?
Yeah, so the PPE questions that we have in the survey, oops, sorry, hang on, let me go back. The PPE questions we have in the survey, so there's 2 things to which reports. They did give a number of examples, so things like masks, face shields, gowns, gloves, but they weren't specific. So we don't know things around the type of masks that were available. We don't know things around access. So we know about access, but we don't know about compliance. So we don't know about whether there were policies in place to make sure people were actually wearing their PPE in the workplace. And so there are still important bits of information that we don't know around PPE. And again, some of the details about the particular type. So were the masks that were available, were they surgical masks, were they N95 masks? We don't have that level of information in the StatsCan survey.
Thank you. There's another question about contact tracing and whether or not you feel like the data has appropriately picked up some of the work that was done by Public Health Ontario to trace outbreaks.
Yeah, so I guess so the workplace outbreak data is restricted to cases that are associated with that particular outbreak. Public Health Ontario, so there's a paper in the Journal of Occupational and Environmental Medicine by Michelle Murty. And if people want to, they can email me, I'll send them a link to the paper, which did try to estimate during the first wave of the pandemic, the number of household cases that could be attributed back to a workplace outbreak. And they did that by looking at residential addresses and COVID transmission rates. And they found that about, for the 12% in our study of cases that are attributed to workplace outbreaks, you could increase that by 50% to take into account the subsequent cases that occur among household members. So I guess if you wanted to use a very broad definition, about 18%, you could estimate that 18% of cases among the working age population were due to, started with a workplace outbreak. Again, workplace outbreaks can also start with household transmission and community transmission. So it becomes, very complicated to start using this logic. In the end, you'd sort of say, well, 100% are due to travel because COVID probably got in through travel. So we need to be careful in terms of the attribution, but there has been work from Public Health Ontario to try to estimate the number of subsequent cases that are due to workplace outbreaks. We also don't know the extent to which how workplaces were, or how public health units were in terms of sensitivity to detecting workplace outbreaks. So did that differ? For example, we know in Peel, for example, they seem to be very aware of the potential for workplace outbreaks, although the levels or the proportions of cases due to workplace outbreaks in Peel were no different than it was in the general population that I've reported here. So among health regions where we think they were maybe quite sensitive to it, we didn't see increased rates in those health regions.
Thanks, Peter. There's also a similar question around for agricultural workers. The congregate living situation was potentially mistaken or miscounted, not as a workplace outbreak, but would have been categorized under congregate living. Can you comment on that?
Yeah, so I think this is one of the big challenges in that there isn't sort of risk and no risk settings. And there are workers where it's complicated. One of the other complicated around agricultural settings in terms of the information I presented today, we have problems both in the numerator, so maybe we haven't captured cases that have occurred in the accommodation and compared to cases that have occurred in the workplace setting, although even being able to distinguish between those cases I think would be extremely challenging at the public health unit perspective. Within the denominator, the labour force survey data, the temporary worker population isn't included in that denominator. Also, there are a number of workers in agriculture who say they're working from home, but their home is the farm. So, you know, there's I guess a large number of suggested improvements we could make at this point as to how we might better capture that information. But I think these limitations are valid in terms of those settings. I will note that, you know, agriculture is about 3% of the cases, and so while it has a very high rate, it's not the driver of where most cases are coming from. It's a relatively small industry group compared to other ones.
Thanks. And if you could show slide 27, because there are a couple of questions about that, about the size of cases. And there's people saying, thank you, great presentation. They appreciated this work. So the distribution of workplace outbreak sizes or cases, just how much does that reflect the distribution of workplace size in the province?
Yeah, I mean, obviously the size of the workplace will be one of the primary drivers of the size of the outbreak. And unfortunately, like a number of the limitations I've discussed today, we don't have that information. We don't know the size of the workplace in which each of the different outbreaks occur. However, it would be interesting. I mean, I think that's a great question. It would be interesting to try to understand if you looked at workplaces that were a similar size, so workplaces that employ 100 to 200 employees. What distinguishes, when an outbreak occurs, what distinguishes the outbreaks that are 5 to 10 employees from the outbreaks where there's 50 employees? I mean, we saw in the news, the media were very good at reporting the extreme cases throughout the pandemic. So yeah, we saw in different manufacturing facilities and postal services where there were extremely large outbreaks. So what was happening in those particular settings that wasn't happening in other settings? And I think these are missed opportunities throughout the pandemic that we could have invested time in better understanding that. And certainly we need to set up systems where we can access that information quicker for the next pandemic. We know there's more than likely going to be another pandemic, and by correcting and by better integrating public health with occupational health, I think we can do a much better job for the next pandemic, where we can work much more quickly together, integrating the knowledge that we have around the workplace with the knowledge public health has around disease transmission.
So it's not as simple as saying that it's larger employers that tend to have these outbreaks.
Well, obviously, you'd be unlikely to get an outbreak of over 100 in a workplace that only has 20 employees. But I guess we don't know. There's been plenty of large employers who haven't had outbreaks, or when they have had outbreaks, they've been relatively small. But we don't have consistent data collection to enable that I guess for us to better understand that. I think one of the things I wanted to show in this particular slide is more just that similar to what we've observed in non-outbreak settings, is that there does seem to be situations where COVID seems to spread very easily and rapidly, and other situations where it doesn't. And there's a lot of factors, both at an individual level and at a work context level, that I think are important here. And I think what this slide suggests is that, yes, we've observed some very large outbreaks, but we've also observed even more very small outbreaks. And if we could do a better job at like trying to pair up and take into account size, factors around size, we might learn even more about which of the environments where COVID transmission seems to occur rapidly and which of the environments where it didn't.
Okay, great, thanks. And backing up a little bit, defining outbreaks. So there's somebody from another province, they didn't say which province, but they said that their province didn't have a consistent definition. So what was the definition that you were working with, or that the province here was working with?
Yeah, so outside of healthcare, through the majority of the pandemic, it's been 2 cases that it can be linked. So they couldn't be linked through anything outside of the workplace. And this comes back to one of the previous questions about congregate living or people who are commuting to work together. So it couldn't be linked to that activity, but could only be linked to the workplace. So it is a restrictive definition. And we acknowledge both in the paper and in the other work we've done that it likely underestimates the number of cases that are due to workplace transmission, where a single case occurs, or where it might have occurred at the workplace, but it could have also occurred outside of the workplace. In terms of at the start of the pandemic, healthcare declared outbreaks with a single case. That changed throughout the pandemic. But again, while the definition is consistent, we don't know that the application of the definition is necessarily consistent across public health units. And that's another thing to take into account. When we did look at potential differences, so for example, we said, well, maybe in some health regions where maybe they weren't attuned to workplace outbreaks, where they didn't sort of note that the workplaces were important, that maybe they'd have less, and we didn't see that. And in other regions where they were more sensitive, we'd see higher cases attributed to workplace outbreaks. Again, we didn't see that. As I said at the start, like in Peel, the rates of outbreaks, again, it was similar to what we observed, in fact, a little bit lower than what we observed in regions which weren't Peel, and in terms of the cases attributed to workplace outbreaks.
Okay, thank you. Now, there are a couple of questions about carpooling and whether or not that would have been considered, well, often not considered a workplace, so therefore not counted, but were there any cases where you think that might have been accounted for?
Yeah, so we do know, so both from the Ontario setting, and I also know in the UK, for example, there was a lot of, I guess, work-associated cases of COVID, which were not, which wouldn't have been counted as a workplace outbreak, but would have been included as a close contact. So these include people chatting outside of the workplace, so not in the workplace setting, people having lunch together in a lunchroom and taking off their masks, which wouldn't be considered a workplace outbreak, and people commuting together, which wouldn't be considered to be a workplace outbreak. I think this demonstrates, you know, the information at the start of the pandemic that I don't think we did a good enough job to indicate that this is a human-to-human transmission. This is not about people who are symptomatic transmitting it to other people. So you shouldn't only worry about people who are symptomatic. You should worry about anyone can potentially submit COVID, and they can potentially transmit it, as we've now come to learn, through air and through droplets, with less transmission, in fact, negligible transmission occurring through surfaces. So there wasn't a lot of and potentially, I guess, you know, with that information, with complete information, maybe we could retrospectively go back and assign outbreaks to workplace outbreaks. But yeah, is it a perfect measure? No, I don't think it is. Is it the best measure we have available? Yeah, I do think it's the best measure we have available to better understand what is work-related transmission compared to non-work-related transmission. It's an underestimate, but it is the best measure we have available. And you know, as an organisation who doesn't push further than the science, that's the findings we're presenting today.
Okay, thank you again. And ventilation has come up. Was that considered in the infection control specifically? Could you comment on that?
Yeah, so it wasn't, and I think that's a limitation. So, you know, when StatsCan were designing their survey, which would have been probably in May, June for administration in July, August and September. They didn't include an assessment of ventilation, although, you know, you might, and I'm sure our friends at OCAL can answer this in more detail than I can, just the ability for an individual worker to be able to assess the ventilation in their workplace, I'm sure would be challenging from that perspective. So I think, you know, ventilation, understanding ventilation, and again, I'll say both in workplace and non-workplace settings, is an important thing that we need to do to understand rates of transmission that have occurred and how they've been related to ventilation. You can certainly see it in some of the information I've presented around why we've observed very poor infection control practices in construction with very low rates of COVID transmission. You know, certainly has something to do with the proportion of people working outdoors in those settings. And again, that provides, again, more evidence that airborne transmission and ventilation are important factors when it comes to COVID-19. Again, when we see in food manufacturing, why are we seeing relatively high rates of infection control practices based on physical distancing and PPE and access to hand washing, but yet we're also seeing high rates in food manufacturing compared to non-food manufacturing? Again, points to the suggestion that this is COVID spreads through droplets and through air, and in cold environments, it tends to spread more than it does in warm environments. So I think these are important learnings to try and understand these distinctions between why has it occurred in some settings and not in others, even taking into account infection control practices.
Yes, and the audience was also commenting on that. How do you explain that? How do you explain that there is poor protection at construction industry workplaces, yet they have some of the lowest? So thank you for answering that question in advance. Another question is about judging whether or not transmission was actually happening at the workplace or not. And I think you've kind of gone there, that it's hard to know exactly if the tracing isn't perfect, and it's not a perfect world, but maybe you could further explain how this data is elucidating workplace outbreaks.
Yeah, so I think there's two things I think which are worth noting here. One is that, yes, workplace outbreaks are where the spread definitely occurred in the workplace. And if it could have occurred in the workplace, but maybe could have occurred somewhere else, these would not be included as a workplace outbreak. I think the other learning that we've made at the Institute for Work and Health and with colleagues again in the UK and the US is that the risk of transmission is never zero, it's continuous across settings. And the people who are at risk in a workplace setting also have multiple risk factors outside of the workplace, such as crowded housing, such as densely populated apartment complexes, such as taking public transit to work. And so it's really challenging when you've got all these risk factors occurring within a particular segment of the population. It's really complicated to disentangle, well, how did COVID transmission occur? You can't default to say it occurred at the workplace, and you can't default to say it didn't occur at the workplace. You've got to use the data that's available to try and distinguish between workplace and non-workplace outbreak cases, and that's what we've tried to do here. But it's important to recognise that COVID is, like almost every other disease that we face in society, disproportionately affects disadvantaged populations. And those exposures can be at work and not at work, and we've seen that with COVID. We've seen it affects particular neighbourhoods and particular segments due to work, but also due to a variety of other non-work related factors as well. And while it might be convenient to attribute spread to the workplace, because it's easier to target workplaces than it is to target neighbourhoods, we also need to think about living conditions that people have and community conditions that people have as part of an effective prevention strategy when it comes to COVID-19.
Well, thanks, Peter. There is a question here also about racialized workers and looking into the possibility that they're having increased transmission outside the workplace as well as a potential factor that had skewed the data to make it look like workplace transmission.
Yeah, so let me offer two findings there, which are interesting around race and immigrant groups and even deprivation. So one of the things we found, certainly in the protections study, was we didn't see any differences across hourly wage, although we did see it among low educated workers, and no difference across race groups. in the PHO study on workplace outbreaks, while we observed higher rates of workplace outbreaks in the most marginalised populations, that proportion that those outbreaks contribute to all cases was lowest among those populations. So the contribution of workplace outbreaks are greatest among the least deprived communities and lowest among the most deprived communities. And among marginalised populations, again, proportions of workplace outbreaks were highest among the least racialised groups. And so, again, there's this complexity of factors that I don't think has been fully appreciated when it comes to COVID. And again, disentangling them isn't a simple task, but with the right data collection and addressing these limitations in our current data collection now, we can do a better job the next time we have a pandemic to understand how disease distributes among society and what's the contribution of workplace to that spread.
Mm-hmm. Interestingly, the person who was out of province, and if you could let us know what province you're in, if you want to, that'd be great to hear. But they found that food processing, had a high proportion of racialized workers, but excellent control measures. So thank you for that comment. Another question was around super spreaders. Are there situations where COVID-19 spreads particularly reflecting that? And how would you account for ventilation on top of that? So it's a double question, but first address super spreaders, please.
Yeah, and I think we've got this slide up still. I haven't put it back to my email, but I mean, I think if you look at the non-workplace outbreak information, a lot of that is due to the super spreader. So people have, some people have an ability and they're extremely effective. They've got a high viral load and they're extremely effective at spreading COVID through the air and through droplets. And so they can infect, again, in non-workplace settings, that shows that most of the time it's just one or two people, and then sometimes it's hundreds of people because you get someone who's got a really high viral load and a great ability to spread the virus. Asymptomatic transmission is also something which we don't fully understand. Understanding how asymptomatic spread is, like how common was it for people to have COVID asymptomatically and how effectively could they spread it when they were asymptomatic? Again, as rates come down, we should be really pushing to do more about asymptomatic testing in settings that we know are high risk, so where things could occur. I think there are some industry groups that have done a great job throughout the pandemic. Some of the construction industry have done a really effective job at doing a lot of testing before people enter the work site. So I think, again, the more large employers who can do that, the better. So I think it's a lot more complicated than I think we realise. Just around the factors both at an individual and contextual level that contribute to the spread of COVID-19. I'll go back to my other slide.
Thank you. Very complex indeed. There is a question, backing up again, about defining workplaces as workers go to different sites sometimes. Was that part of the survey, getting at that?
Yes, that's a complicated question. So what would happen if there was a workplace outbreak occurred for someone who worked at multiple different locations? So I don't know the answer. We don't know enough about how public health units are, how they assign workplace outbreaks to different settings. If it occurred in both settings where the worker was, where is the case attributed? I don't know the answer to that, but I think, again, thinking about multiple job holdings, we know at the start of the pandemic, some of the changes in British Columbia around stopping long-term care workers working in multiple different homes were effective in reducing the spread at that stage of the pandemic compared to other provinces. So I do think, again, thinking about how people move and why people have to move between jobs is important in terms of understanding disease transmission as it relates to work.
Mm. And there's also a comment here around the complexity of studying this, so that living conditions often reflect economic status and the lack of sick days, so it is hard to disentangle some of these issues. Thank you for that comment as well from our audience. And there's a question about working from home, and there was a factor of working from home that you pulled out, but this person just wanted to get clarification on accounting for that ability to work from home. If there's those with a higher rates of COVID-19, if there are more workers at work compared to other sectors and workplaces where fewer people are going to the workplace?
Yeah, so in the second study, we are using hours of work outside of the home. That's the denominator. And so that was one of the huge improvements in that study compared to pretty much everything that had been done to that point, is that we were able, Statistics Canada was able to ask workers each month, where did you spend the majority of your hours and how many hours did you spend? Noting that for a lot of workers, they were working fewer hours than they would normally work. And so within each industry group, it's the hours of exposure in the workplace is the denominator. And then we've compared that to 16 hours of exposure in general for the rest of the population. So that is one of the things that we were able to do in that second study, which was a real improvement compared to guessing if people still had their job and if they were actually going to the workplace, which is what you had to do if you were using census data to estimate these things. And so the labour force survey did have this question where we could accurately estimate how many hours were being spent and how much did it differ across each of the different industry groups. So then one of the things we found surprising was just how many workers throughout the pandemic, even at the start of the pandemic, we observed that more than 50% of the workforce was still going to the workplace, which we found surprising. And maybe that's our sheltered environment in academia and a research organisation where we all work from home, so we assumed that almost everyone else was, but it was the fact that there was a lot of people, somewhere between 50 and 70%, who were continuing to go to the workplace throughout the pandemic.
Thank you. Since we only have a few minutes left, then maybe we'll both look to the future. There's a question about that, and then also get you to summarize on what you think improved data collection looks like. So first, to the future, someone was saying that they think, management in response to employees and limiting the spread of COVID-19 might consider changes of furniture, changes of office environments, for example, as people transition back to the office. Wider and spacier places to work. So how would these measures help reduce the transmission, do you think? And what might the future of the work environment look like in your mind?
Okay, well, I feel like you're pushing right out of my comfort zone. Given surface transmission is probably not a major route, I don't know about changing office furniture. I think the best people to talk to when you're thinking about changes to your work environment is the Occupational Health Clinic for Ontario workers. I think they've done a lot of work trying to understand different protections and workplace risks, and they do provide advice to workplaces. And so I would say, contact OCAL. I think we can probably put the link in the chat. Health and safety associations, various health and safety associations around Ontario are also excellent sources of information and advice about things that workplaces should do. So I would encourage people who are interested in understanding what should a workplace do to contact either the Health and Safety Association or the Occupational Health Clinics for Ontario workers. Is that the answer today? Was there a second part to that question?
No, there's another question, but thank you for that, for going out of your comfort zone and outside of the realm of this research. But to summarize for this research, there's a good question about where you think data collection could go now. How do we improve data collection, and with which agencies do you think this data collection should lie?
So I think first, public health has got to recognise that work is an important determinant of health, not just for COVID, but in general. When we talk about 12% of cases being attributed to workplace outbreaks, 12% of diabetes cases among women can be contributed to low job control. 12% of hypertension among men can be contributed to low job control. So work, regardless of what you're talking about, is an important determinant of health. I think we can do a better job in our administrative data for healthcare and collecting information on work. So emergency department data collects information on whether it occurred in the workplace in terms of attributing payments, but a couple of simple questions about what type of job do people do, and emergency department records could fill in huge information gaps in the province. Better using linked data, so asking more questions about work in our population health surveys and being able to link that to future disease is again another area where we could have improved. I think one of the things we've learned around COVID is that we should have got into non-healthcare settings quicker, in particular settings like food manufacturing and other manufacturing organisations, to understand how COVID was spreading in those environments. Had we gone into a couple of very large organisations, I think we could have learned things much quicker than we did. I think a lot of the focus at the start was on healthcare, and a lot of that focus was about worrying about healthcare workers spreading it to patients. One of the things I think we've learned is that this is a disease that spreads from person to person, and getting into non-healthcare settings quickly, I think we could have learned a lot by doing that. And so that would be my short take-homes. And I think we can start that. We should be starting that now, not waiting for the next pandemic to occur. But we can set some of these things in place now.
Okay, everybody on this webinar is going to go out and do their bit for that. Thank you very much, everyone, for joining us. Excellent questions. Peter, thank you very much for your presentation. The slides will be ready in 2 weeks this time. And I'd like to point out that on November 9th, we are having another speaker series by Kathleen Dobson, a new scientist at the Institute, and she will be uncovering the impact of a depressive episode on employment earnings of workers. So stay tuned for that, and thank you again for joining us today.